I'm Dr. Cliff Davis, Assistant Professor at USF and partner at Radiology Associates of Florida and Interventional Radiologist at Tampa General Hospital. This video is going to briefly cover chemoembolization, a procedure performed by interventional radiologists. Chemoembolization is a procedure which combines delivering a chemotherapy agent directly into the arteries, feeding a liver tumor, while simultaneously blocking off the blood supply to the tumor, termed embolization. It is typically used for liver cancer called hepatocellular carcinoma or HCC, but can be used for other types of tumors that arise in the liver. Chemoembolization was developed about 25 years ago and shown to shrink the tumors in the liver and improve survival in patients with liver cancer. During chemoembolization, a tiny catheter about 1 millimeter in diameter is threaded from an artery in the groin or in the wrist to the arteries in the liver under X-ray guidance. Once in the liver, advanced X-ray techniques are used to determine the blood flow to the tumor, and once the direct blood supply is identified, a combination of chemotherapy or particles are infused directly into the tumor until the tumor is saturated and the arteries are blocked off. This kills greater than 75% of the tumor and can occasionally kill 100% of the tumor. Prior to chemoembolization, all patients are evaluated in our clinic or by telemedicine. We need to review current blood tests for underlying liver function, your overall health, signs of liver failure, or other symptoms that may increase your risk of complications. Your current medications will be closely reviewed. We will also need current imaging such as a CT or MRI. These imaging studies must be performed utilizing special techniques to visualize all the tumors, so we may repeat them after clinic if we feel they are not adequate. Most patients with liver cancer or metastatic disease can get chemoembolization. However, other techniques may be more successful, so we closely review all of the options such as surgery, ablation, which is burning or freezing the tumor, or arterial radiation therapy called radioembolization. Often the decision for the best procedure is performed prior to your visit with an interventional radiologist, oncologist, and surgeon. Patients with advanced liver failure should not get chemoembolization as it can progress to fulminant liver failure, which can be fatal. Review of the patient's labs and symptoms help us make the decision for who is safe for treatment. As previously described, the procedure is performed in a special operating room under X-ray guidance. Access into the artery is usually in the left wrist or the groin, which then allows us to guide the catheter to the arteries in the liver to the tumor. Patients are under twilight sedation, which allows them to be woken during the case, but generally they do not remember the procedure the following day. The procedure takes about 1 hour, but the patients will be at the hospital for at least 6 hours. Patients with large tumors that require treatment of a large portion of the liver can get nausea and vomiting with fever and pain over the liver after the treatment. If we suspect that will occur, we admit these patients overnight and treat them with IV pain, nausea, and anti-inflammatory medications. In the vast majority of patients, the pain, nausea, and fever resolves by the next morning, and the patients are discharged before 9 a.m. After discharge, most patients feel fatigue and sluggish for a few days. Pain over the liver can occur, but shouldn't be severe. To determine how successful the treatment was, we schedule the patients in clinic 4 to 8 weeks after chemoembolization. We obtain repeat imaging and blood tests prior to the appointment to evaluate the tumor size and liver function. If the tumor is not showing any signs of growing back, no further treatment will be performed, and we will follow patients with a CT or an MRI every 3 months. The major risk of chemoembolization is worsening liver failure. There are very minimal risks of injury to the arteries in the liver or allergies to the chemotherapy or contrast. It is very rare for patients to lose their hair after chemoembolization, and rarely do patients lose their blood counts as seen with IV chemotherapy treatment. We often work with other cancer specialists and surgeons to determine the best treatment for each patient. Discussion of liver transplant, surgery, and use of chemoembolization with IV chemotherapy, called systemic chemotherapy, will be discussed during your clinic. Chemoembolization can be performed several times on one patient, depending on their underlying liver function. Frequently, chemoembolization is used for patients waiting to get a liver transplant or in combination with other treatments to keep control of the tumors and prevent new ones from developing. We hope you found this video educational, and thank you for your time.